after diastemas, we can see spaces between the lateral incisor and the canines, between the upper centrals and between the upper laterals and upper right and left canines. Let's take a look to the lateral X-ray. We can see an increased curve P, an extreme proclination of the upper incisors, and a very hard to achieve retraction of the upper incisors. Why? Because of the fact that the lower incisors are severely extruded, and this is a consequence of the very deep curve of P. The upper incisors cannot retract because they would hit the lower incisors, and this would generate a severe trauma. So the first step in this case was to intrude the upper lower incisors. Let's do some considerations together about the lower intrusion need of the patients. We have we share the need to intrude the upper, to level the lower curve of P, because it's impossible to retract the upper incisors. But our question is if it's possible, whether it is possible or not to increase the vertical dimension of occlusion in this patient with a very strong muscular activity. We know from the literature that extrusion of posterior regions is for sure stable during the growth, but unfortunately it's unstable after the growing period. And we know from the literature that Segmentary Technique allows us to intrude lower and upper incisors with no or insignificant posterior extrusion. And this is the reason why we decided in the Paulo's case to start by intruding the lower upper incisors. We know that to obtain a pure intrusion of the lower incisors is quite hard with continuous arch wire for two reasons: because the intrusion forces act buckle to the center of resistance of the lower incisors, and this creates a tendency for the incisors to flare. This is the first reason. The second reason is that working with continuous arch wire, it is very hard to create the exact very light amount of forces indicated for a pure incisor intrusions. This is the reason why we decided to use, in this case, the Segmentary Technique in order to obtain a preliminary intrusion of the lower incisors. We started by intruding the lower incisor, and I would like to share with you some details of our appliance. We have passive sectional wires 19x25 bonded directly on the enamel of the lower incisors. This is a flow reason. The reason is connects a 19x25 stainless steel wire to the enamel of the teeth. And then we have a 17x25 TMA intrusion wire which intrudes the lower incisor. Here we can share a detail of the ligature of the intrusion arch wire. Let's take a look also the posterior setup of the appliance. We have considered together the presence of the 19x25 stainless steel wire connecting all the incisor for the flow reason on the enamel of the lower incisor. Then we have a 17x25 TMA intrusion arch, which is connecting the anterior dental unit given by the block of the four incisors to the posterior teeth. The solid stiff 19x25 stainless steel wire makes the four center of resistance of the incisors become just one center of resistance of a group. So we now are discharging the intrusion forces on a block of teeth consisting in all the four incisors soundly connected together. The incisors are intruded, discharging the reaction forces on a posterior block of teeth created by using a 19x25 stainless steel wire first molar, then second premolar, and canine as well, connected together, and the 19/25 semi-steel is bonded with floor resin to the enamel of the corresponding teeth. A 17/25 TMA intrusion arch, as we have seen together, tends to intrude, we can see here in the drawing, tends to intrude the incisor. And here we can observe just two dental units, an anterior block consisting in the lower incisors, and a posterior block in which posterior regions are rigidly connected together. This makes the center of resistance of the different teeth become just one, and the solder lingual arch connecting posterior left and right lower regions makes the two centers of resistance become just one. So we have a system with two teeth working. We have a center of resistance on the posterior unit and a center of resistance at the anterior unit. A 17/25 intrusion TMA wire intrudes the lower incisors. And here we can observe, drawn in yellow, a deactivated supraelastic intrusion arch wire and the system, the overall force system with just two dental units. And this is appliance, the segmental appliance that can seem quite strange if considered regarding the elasticity and the rigidity of the appliance is somehow something quite easy, because just two dental units are inserted in the appliance. After beginning the lower incisor intrusion, we perform enough lower incisor intrusion. So the next step is, the next need is to retract upper intrusion. Let's decide together how to make an upper incisor intrusion, and let's think together about what happens if we tried to use, in this case, a class 1 elastic force for retraction. If we used something as a continuous arch and a power chain, or a class 1 elastic in order to retrocline the upper flared incisors. During the retraction of the incisors, the gingival margin of the incisor will tend to go downward, and the horizontal force, a pure horizontal force, would tend to create a deep bite worsening, and this would make the overbite worsen, and that would be opposite to the treatment goal for our patients. We have, in this case, to consider the use of an intrusive force, which is much more indicated. We could try to apply this force on the buccal side, but that would give us a problem. A buccal force would tend to intrude and even more flare the upper incisor, because it would pass buccal to the center of resistance of the upper incisor. We could try to change the side of the point of application of the force, passing to the palatal side of the incisor, and that would be much more indicated from a biomechanical point of view, because it would tend to intrude and to retract to retrocline the upper center incisor. Of that, it is quite easy to obtain anchorage in the palate, because we can use palatal bars with hooks in order to obtain a point of application of a retraction force. So we decided to skip, in this case, to the palate in order to retract and retrocline the upper incisors. Before going on, I would like to share once more with you the biomechanical scheme, why it's quite dangerous in this case to use an horizontal force, because it would tend to generate a deep bite worsening, and in this case it's quite indicated an intrusive force on the palatal side in order to maintain the good vertical position of the upper incisors. Let's go back to Paolo, and let's go back to his appliance. Here we have an Anchorage device in the upper arch. We have connected, safely connected together, upper upper first molar, the left and on the right side, and the first premolar on the left and on the right side. The connection of the teeth is very stiff because we have 3 transpalatal bars, one connecting the molars and a cross welded bar connected the premolars with the molars on as a cross. With the shape of a cross. All the bars are soldered together in order to obtain a very high rigidity. We have some pins in the posterior, the most posterior transpalatal bar, useful to obtain anchorage for elastics for intrusion and retraction. Elastics positioned on eyelets bonded on the palatal side of the upper incisors. So let's start to retrocline the upper incisor, and after a while teeth start retracting, and then we can go for alignment of the anterior segment, being careful not to lose the good spatial orientation as we've seen in the initial part of our meeting together. And we have the palatal anchorage that is retracting and intruding the upper incisors. Here we have a good incisor retraction, and so after the vast majority of the space closure, we can go for a continuous arch wire and going for finishing and detailing with minor aesthetical issues. Here we have final records with good overjet and overbite correction and good stable posterior occlusion maintenance. I would like to show you final OPT of the patient and final lateral cephalometrics with the good leveling of the lower curvus P and the correction of the flaring of the upper incisors. Now let's summarize some things together, and let's go to the final part of our meeting of today. The segmentary technique is based on the strong distinction between active and reactive unit, meaning teeth to move and teeth not to be moved. It's based on the use of different sections and different materials of the wires. It is based on the different stiffnesses on the wires. A very important point of the segmentary technique is the possibility to generate very light forces and to generate a system of forces ideal for specific movements, different specific movements. And now let's go back to the initial example we did when considering a continuous aligned arch wire. And let's do some consideration about the initial positions of the teeth. We may imagine that there are some teeth in a good initial position, such as the teeth colored in green. We have molars, we have some premolars, some canines, and 2 incisors in a good initial position. So a question could be, do we really need to move them? There are some other teeth that are in a bad position, and these are the teeth colored in red. So we have teeth in a good position, colored in green, and teeth in a bad position, colored in red. A question that we could ask ourselves if it is really necessary to move the teeth in a good initial position, or if it's indicated to move only the teeth in a bad position. Should we decide not to move some teeth, we could decide to share them together with rigid wires. For example, 19/25 running on the incisors in the brackets on the buccal side, and transpalatal arch running on the palatal side of the upper first and the upper first molars. This could create a solidarization, a very rigid unit of the posterior teeth in a bad position. Here in the frontal region we have an incisor that we are supposed to be in a good position, and we might decide not to bond it. So we could even remove the brace on the bracket on this tooth. We could even remove because it's in a good position and we don't need to move it at all. And now let's go back to the example we did at the beginning of the treatment when we considered the palatal displacement of an upper second premolar, which is displaced in a crossbite position in the palate. If we decided to have a selective movement of the premolar in a buccal way, we could consider the choice of the segmentary technique. The technique allows us to maintain still, not to move the teeth that are in an initial good position as the first molar and the first upper premolar. In order to prevent any undesired movement of these two teeth in a good position, we could use a stiff sectional wire 19/25, for example, inserted in the braces of the molar and the first premolar. And we might connect the molar to the opposite molar in order to obtain a very stiff, a very sound dental unit. This would allow us not to move the upper molar and the upper first premolar. Regarding the second premolar that needs to go outward, we could apply, by using the segmentary technique, the ideal force system that makes the tooth go outward. And this is a single force passing through the center of resistance. And this force can be generated in so many different ways. One could be, for example, a cantilever, as we have seen in some clinical cases before, a piece of wire bent in order to generate, once it has been ligated to the upper second premolar, a single force pushing the premolar outward. I would like to show you one last case and to summarize all we have shared together. Let me introduce you to Mohamed. He's another patient born in Egypt and now living in Italy. It's a patient that, who lives in Turin, but he was born in Egypt. He's a very nice boy, and he came to me complaining for his big diastema between his upper incisor. This is a very evident aesthetical issue. Mohamed has a good posterior occlusion, has only sacral S, and he has a limited possibility of expense, so he cannot afford very major treatments, and he has an altered Bolton index. And considering the altered Bolton index, we know that we need to correct in a stable way the anterior occlusion. We need to enlarge upper incisor of 3.5 millimeters. And we decided with the restorative dentistry to close the diastema between upper central incisors and to create a space mesial to the upper right and left lateral incisors in order to obtain the space to add some materials, to add some composite, enlarging the upper lateral incisors. We decide to close the diastema in the easiest way possible for two reasons: because patient has an excellent posterior occlusion that we don't want to change, and the patient asks us quite easy way to correct this problem. So we go to the biomechanics and we decided to create a very easy, a very basic appliance designed by the biomechanics principles. Let's think together about where are the forces needed to close in a bodily way the diastema, the gap between the upper central incisors. We know from the biomechanics that the force required passes through the center of resistance in a frontal way. But we also know from biomechanics that this is that is valid from a frontal point of view. But from a coronal, from an occlusal point of view, it is not possible to apply the force passing through the center of resistance, because the forces cannot be applied inside the tooth itself. So we have two options: to apply them on the buccal side, but this would give us a problem, because the teeth would tend to rotate, to mesorotate reciprocally while closing the diastema. Or we have a second option, so no way to apply the forces from a buccal point of view. We could switch to the palate, skip to the palate, but we would have an opposite problem, because while closing the diastema, the teeth would rotate in a distal way. The solution we decide to use is to apply a force both on the palatal as in the buccal side, creating a so-called double cable mechanics, which means to apply forces on both the sides of a tooth to prevent undesired rotation. And this is what we decide to do. Very easy cases for Mohamed. We decided to use a basic segmentary technique with a reciprocal anchorage, meaning that both the incisor go together, going to close the diastema. I would like to show you the system, the appliance. Very easy. We have a bracket for upper incisor with a vertical slot underneath the main 22x28 slot, and in the vertical slot we have a power arm that allows us to apply an elastic power chain at the same height of the center of resistance of the upper incisors. We also have a guide wire useful to prevent undesired movement of the incisors, and this is a bigger picture of the appliance. We can see something from the palatal side, because it has been bonded to braces on the palatal side of the upper incisors, whose role is to apply a palatal force. We started in December 2011, and the teeth were in contact in February 2012. And after that, we decided to remove the braces and to ask the restorative dentist to enlarge upper lateral incisors. And this is the final result. I think it's quite easy. It's quite good results. And the initial and the final records. And in the final records, I like to share with you the very nice posterior occlusion, and this was possible because of the fact that the posterior occlusion was not modified at all. This is just natural dentition of the patient. We just moved in an exclusive way upper right and upper central incisor, closing the diastema. No other thing, no other tooth was touched at all. And so this is the very nice natural occlusion of the patient that I personally do not want to change, because I can't do better than this. And this is the case at the beginning of the end of the treatment. Here is a follow-up from May 2013. And now we can go on the very final part of our Zoom meeting together, talking about very fast about the tools of the segmentary technique, which are wires with different stiffness, wires and long sticks, and springs of different kinds, cantilevers, which can be used to generate forces and moments in a very different way, loops, bendings done in different way, elastics used to selectively move the teeth, power arms, very useful to apply force the closest possible to the center of resistance of the teeth to obtain a bodily movement, and then transpalatal bars, lingual arches, very useful to apply to increase our anchorage. And so let's go to the flow chart of TAF in segmentary technique. That is quite different from straight wire approach. The first question we ask ourselves when we do some segmentary technique is, which movement do we want to perform? The second question is, which is the proper force system we want to able to obtain that specific movement we want to obtain. The third question is, where can we discharge the counter force? And this leads us to the concept of anchorage. And fourth, last but not the least, is the appliance design. And it's quite curious to share with you the idea that the appliance design is the last point in the flowchart of TOF in segmented arch technique. And so we go to the conclusion. For sure, the vast majority of our patients can be treated with conventional approach with statewide technique, removable appliances and clear aligners and so on. But a minor part of the patient can obtain benefit from the segmental arch technique approach that allows us to treat the most severe and the most atypical case, and allows us to do very specific dental movement without changing, without altering all the rest of the occlusion. It can be indicated in some specific clinical conditions. The segmental arch technique has for sure a problem, the long curve of learning, because at the beginning it is quite hard to start with segmental arch technique cases, and the beginning is very slow. It is necessary to refresh, to brush up, to sometimes study some biomechanics, some basic biomechanics, but then there is a steep acceleration, results arrive in a very, very fast way, and then we go to a proficiency and then a plateau, and at that point we are able to do segmental arch technique cases. But the risk is to stop ourselves at the initial part of the slope when we see that we obtain results in a relatively slow manner, because studying biomechanics can be quite difficult. But if we do not surrender and we hold on, we can go to the steeper acceleration and we can learn biomechanics. Should you need to study some biomechanics, I would like to invite you to consider the Italian Society of Orthodontics and Segmental Arch Technique, which is called SIBOS. We are an Italian society with international membership possibility, and we give biomechanics courses and segmental arch technique courses, even theoretical and practical. It is now possible to subscribe to become members of our society, but from 2021 the international membership will become free for our international members, because we would like to share, we would like to have new members from all over the world, and we would be glad if you could be interested in our project. I would like to show you some picture about our courses. They are theoretical and practical as well, and can be interested for you if you are interested in these topics. And I would like to share you one of a picture at the end of a SIBOS course. We're a young society, and we will be very happy to have foreigner students with us, and to share knowledge and become friends. So we have now arrived at the end of our night together. It has been a big pleasure for me and for Nazari to be with you, and I hope we can stay and keep in touch with you. You can find our links on our email address. You can find Nazario's email address and my email address. You can write us. We will answer you for sure. Should you want to contact us, you can also find us on Facebook, Nazario Rinaldi on Francesco Fava, and we've received so many friendship requests from Egypt. This gave us so much pleasure because it is so nice to have new friendship from all over the world. So should you want to keep in touch with us, do not hesitate. Let's link together on the social network. It's a big pleasure to be here and a big honor for me to be here with you. And I think now we can go for final questions.
Thank you, Dr. Francesco.
Thank you.
Thank you for your fruitful and informative lecture. Just a minute to start my video. I have, do you listen to me? Do you listen to my voice?
Perfectly.
Okay. I have a lot of questions, but I'm trying to select a group of them. The first question was from Dr. Sigalian Uztak. He asked, do we need lingual arch when doing intrusion to lower incisor with TMA?
Thank you for the question.
Yeah.
I try to use the whiteboard, share screen, whiteboard. Yes, it is most of the time indicated because the reaction forces of the intrusion are extrusive forces. I try to do my best with a very basic drawing. Yeah. I'm not Picasso.
You are?
I'm not a very good...
Yeah.
My son is 6 years old and is much better than me in drawings, but now he's sleeping. It's late. I can't call him. It's late. I like to share you a very easy drawing. Yeah. Here we have, from a frontal point of view, the lower first molars, and we have an intrusion arch wire. I'll draw it in a different color so it's easier to... where can I change the color? Draw, eraser format. I want to draw it in yellow. Ah, very nice. Ooh. We have an intrusion arch wire. I change the colors again. We have forces of intrusion that generate extrusion forces on the reaction unit. So the molars will be loaded with an extrusive force acting buccal regarding the center of resistance, and it will lead the molar to extrude but also to lingualize because of the fact that the force is applied buccal to the center of resistance of the lower incisor. For this reason, it can be considered the indication to use a lower lingual arch that I draw this way. I hope I answered to the question.
Yes, yeah.
Should not be clear, the colleague can write on the email or...
No, it's clear. It's clear for us. Thank you. Another question. I think we have two share in the same question. The first is from someone. He did not mention his name. He asked you, in the last case, the force of intrusion for the lower incisor. The force direction were labially to the center of resistance of this group of teeth. Why you counteract? No, I think he asked what, how you can counteract the flaring during intrusion of the entire incisors.
Thank you for the question. I go back to the presentation, so I can. In this case, I had two possibilities to new share. Let's do one share. Okay. In this case, I had to decide where to bond the incisor unit, and I decided to go buccal to the lower segment because I think that the case of the question is this one. Okay. I decided to bend here, to ligate here the intrusion arch, because the other option that I had in order to prevent any flaring of the lower incisors was to extend the segment distal, to the lateral incisors and use not a single intrusion arch but two cantilevers for the intrusion. I preferred not to adopt this configuration, this setup, because I was scared that the patient that had a very strong occlusional pattern could break the device. I would like to once again make a drawing if it's indicated, if it's quite curious, but I would like to answer in the most possible complete way. We have 6, we have 5, we have 4, 3, and we have a group of lateral incisors and central incisors. So we can draw here 1 and 2 with their roots going slightly to the back, and we have the center of resistance here. I decided to bond the wire on the buckle position, and this has for sure created a relatively short distance between the point of application of the force and the tendency of the tooth to flare, and this is sure. The other option was to bend the wire in along the projection of the center of resistance, but I was scared that this would could create some problems of integrity of the appliance. I want to share one last thing about this question. Is I think I did in this case. I ligated. I think that we can share together. That could be interesting for the colleague. I made a stainless steel ligation. I hope it is possible to see here, or just look into for the image in which you can see here. You can see a metal ligation used to try to prevent a flaring of the lower incisor. That was a trial in order to a way to prevent an excessive extrusion of the lower incisors. I want to share one last picture. This is the initial position of the beginning of the incisor. I considered as acceptable a slight proclination that could help me in leveling the lower corpus, but the question is very good.
Okay, thank you. Another question, Dr. Francesco, from Dr. Tabarak. He asked, what about patient aesthetic consideration in presence of many anterior metallic wires?
Sorry?
What about patient aesthetic consideration in presence of many anterior metallic wires?
In which case?
I think that the question is general. It means the acceptance, l'accettazione del paziente di avere tutti questi fili metallici.
It can be a problem when if patient requires no braces at all. Segmentary technique has a big advantage in respect to other possibilities, and it's very fast, gives very quick results, and it gives us some advantages. When considering the importance of the reducing the the aesthetical impact, we can go for aesthetical braces, or maybe we can try to go to the lingual side of the appliance, and that can be an option. But if the patient does not accept any metal in his front side, it can sometimes be a problem, of course.
Thank you. Hi, Dr. Nazaro. How are you? Another question also from Dr. Muhammad Tawfiq. In Paulo case, how can we control the proclination of lower incisor which are accompanied with intrusion using segmented arch? I think you already answered this question. Yeah, you already answered this. Another question from Hassan Agbinar. Do you use TBA, transpalatal arch, and segmented arch technique in most cases? Would you recommend using mini screw instead of transpalatal arch?
While doing the question is referred while doing segmental arch technique.
No, he asked in this technique, in segmented arch technique.
Yes.
Do you use transpalatal arch in most cases?
Yes, we
yes.
Do.
He asked, would you recommend using mini screw nested off as an alternative to transpalatal arch?
Yes, it can be considered an option. I think that we need to consider the fact that we need to insert the mini screw, so we need anesthesia and things like that, and we risk to lose the mini screw. We know from literature that about one screw on 5 tends to become loose, and this can reduce the reliability of this option. But in many clinical cases, or in mutilated occlusion with loss of many teeth, mini screws can be an excellent option.
Thank you. Another question from Dr. El Hassanin. He asked, why use dental anchorage from opposite side and not using indirect anchorage by mini screw?
We use dental anchorage from
opposite side, the other side.
In which case?
Yeah, I think in most cases you insist to adjust the occlusion in post side, because you consider the occlusion is very important. Not to disturb it during the treatment.
I think that maybe the question could be regarding this case.
Maybe, and I think also in other cases. I think he considers the uses of transpalatal arch, meaning you depend not only on the side of movement, but also you take anchorage from the other unit in other side. By using the transpalatal arch, you connect the post segment and make the center of resistance in the middle of the arch as one unit from the opposite side, right?
Yes.
Yes. Okay. Another question from Dr. Zaghloul. He asks, thank you for amazing webinar. He said, according to Nanda, the center of resistance of maxillary incisor during intrusion, it's located just distal to root of upper lateral incisor, right? This is his question, but no question. another but this is good knowledge. Thank you for Dr. Zaghloul for this information. Dr. Dina asked, said, thank you so much for this informative webinar and excellent presentation. I agree with her. It's an excellent presentation. She have 2 questions. First one, for the Francesco patients, could we put buttons on 14 and 15 and 16 with very light power chain buccally and palatally to rotate both? I think she said if he puts the button palatally and buccally and use power chain in alternative manners to rotate them. Is it right? I think this is her question.
It could be an option to rotate the upper first. That could be an option.
Yeah, I think yes. Thank you. Another question also from the second question from Dr. Dina. Do we must always put lingual arch or TBA arch in segmented arch technique? I think you already answered this question.
Yes, it's Bible.
Thank you. Dr. Fadi Fahim, he asked, what is the material and wire size of TBA and lingual arch, of transpalatal arch and lingual arch? What is the material and wire size?
Thank you for the question.
Yeah.
There are two main options. The first option is the 0.36 stainless steel, which is very stiff.
0.6?
0.036.
0.026.
Yes. Write it down. Yeah. Okay. Here it is. 0.036.
For
0.036.
For the transpalatal?
For the transpalatal bar.
Yeah.
It's 0.9 millimeters.
Yeah.
And it's very stiff and allows us to create a good anchorage because it's very stiff.
Nice.
Or we can choose TMA, which is much more elastic and it's very useful to move the teeth. So the guideline is when we want to create anchorage, we need the stiffness. So stainless steel is the best material. If we want to do some movements, today we have just talked about the passive use of the transpalatal arch and bars. The best option is stainless steel because it's much more stiff.
Okay. Another question from Dr. Mahmoud Fathi. He said, in cases of deep bite with diastema, can we do modification with segmented arch by using mini screw with power arm to produce intrusion at the time of diastema closure?
In the case of the first case or the last case?
No, he considered a case of medium diastema with extrusion of the upper incisor, and he wanted to intrude them during a closure of space. He asked, is it possible to use mini screw with segmented arch with power arm to intrude during the closure of space?
I think so. I think that a point to be considered can be the incisor proclination.
Yes.
Because I think that it's important to consider
the possibility of proclination of flaring of incisor.
Yes.
Due to the
mini screw is buckled to the
center of resistance.
So there is the possibility that the force acts buckled to the center of resistance, and the incisor could go
procline, could flare. Yes. Thank you. Another question from Dr. Dario Ribek. How to upright lower molar without extrusion, with intrusion only?
This is a different topic from this topic, and we could discuss about lines of action of forces and TATs, and or even statically indetermined appliances such as alpha beta systems, but could be another topic than today. But a good way to maintain vertical position of the molar while doing while performing an uprighting can be using the mini screw very low in order to prevent the extrusion of the molar. I would like to make a drawing. Very high position of the button, very low position of the screw. So force is intrusive and acts far from the center of resistance. So while the tooth uprights, it tends to intrude. Or another option is loops with vertical control of the position of the tooth.
Thank you. Thank you. Another question from Dr. Brow Shabbook asks, can we use a continuous arch with intrusive arch wire on the lower? What is the difference with the segmented arch? Is it clear, my question? The question
yes.
is clear? Yeah.
A counterposition between a continuous arch wire and segmented arch technique.
Yes, yes.
Continuous arch wire tends to level the curvus P by intruding and flaring the incisors. We have the incisor region. And here we have posterior region. We have an intrusive forces of the posterior regions and incisor regions, and extrusion of the intermediate premolar and canine region.
Mm-hmm.
This generates one main effect, that is the extrusion of the posterior lateral segments, which tends to raise the DVO, the vertical dimension of occlusion, vertical dimension of occlusion. But we know from literature that in the adult patient this is not stable. Extrusion of the lateral posterior segments, it is not stable. Then we have a second problem, which is the intrusion with a force buckle regarding center of resistance, and this leads to an intrusion with a flaring. This is impossible to, very hard to prevent. So lower incisor tends to flare. Then the forces of a superelastic wire, even the lightest force, are exceeding the forces required for an incisor intrusion. We know that to intrude an incisor we need very gentle forces, about 10 to 15 grams. And we know from the literature that even the lightest superelastic wire generates 25 grams. So this is too much to intrude in a bodily way a lower incisor. So this generates a problem that it's not possible to purely intrude lower incisors, and it is not possible to prevent an extrusion of the lateral segments, and this is not stable in the adult patient.
Yes. I think the question was directed to use this continuous arch for all arch with the intrusive arch mechanic, instead of using a segment for the lower incisor only with the intrusive arch mechanics. I think this is the question. And you mentioned by the continuous arch will increase the vertical dimension at the posterior segment, especially at the area of premolar. But concerning the area of lower incisor, you control the movement, the labial movement, or the flaring of lower incisor by tying the lower incisor segment wire with the lingual arch. This is right?
In segmental arch technique?
Yes. You prevent the flaring by incisors of incisor by tying them to the lingual arch.
In this case, I did a metal ligature, but as a general way, the rule is slightly different. We have the incisor segment. Let's draw a central incisor, lateral proclination depends on the force line of action. If the force, as in this case that we share together, passes buccal to the center of resistance, we will intrude and will determine a proclination. If the force passes through, exactly through the center of resistance, we will intrude without reclination. And should we go distal to the center of resistance, we could even intrude with retroclination. This is more difficult from a technical point of view, but in segmental arch technique, the effect depends on the points of the line of action of the force regarding the center of resistance of the lower incisor.
Yes, yes.
In that specific case, I was scared I could flare too much the incisors, so I decided to make the ligation. But the concept, the idea is the point of the line of the force in respect to the center of resistance.
Right. Thank you. Another question. Thank you for your interpretation. Another question from Dr. Burko Bavoso. Sorry for difficulties in the name because
it's an Italian name.
I have a lot of friends from Italy, but I can said her name without difficulty.
Very strange.
I have one is Massimo. Massimo is one of my friend from Rome. But Massimo is the easiest name for me. Dr. Borko asked the other option treatment for closing the diastema. Other option treatment for closing diastema in Muhammad, in the case of Muhammad. Other option treatment for closing the diastema. Do you have other option to close the diastema in case of Muhammad?
Yes, I think we could go purely on the lingual side. I think that could be an option. Another option could be clear aligners. We could use clear aligners with vertical attachment, 4 millimeters, 5 millimeters, in order to control the root position. But this was not possible for budget reasons from the patient. Another option could be an straight wire approach. That could be an option.
Yeah, thank you. Dr. Mina Nagy asked, how can we learn segmented arch mechanics and technique? How can we learn? He said, would you recommend the textbook, or we should rely on basic knowledge of biomechanics?
Unfortunately, the road to the biomechanics is quite long.
It's quite complicated, yes.
It's quite complicated because basics are in biomechanics principles. So a good book in biomechanics is necessary to learn the biomechanics fundamentals. Then the applications are a matter of experience, and I think that sharing the knowledge with other colleagues can be the best choice to compare different point of views. Tonight, Nazari and me have shared some cases, some ideas. Then there are so many good clinicians all over the world with whom share the knowledge and from whom obtain new ideas. And there are so many interesting biomechanic books. For example, I've heard Professor Nanda, but there are so many, Professor Fiorelli, Professor Choi, so many interesting books, and this can be a start for the biomechanical knowledge. And then the segmental arch technique is not a real book, but is just an application of the biomechanical principles. I think, Nazario, do you agree with me, or do you want to add something?
Yes.
Nazario, okay.
I totally agree.
You agree with me?
Thank you. We later on we will ask you to listen in your email a list of book concerning the biomechanics. Okay.
We will answer in.
Thank you. Dr. Amri Mbabi asked how to activate a transpalatal arch for molar derotation and expansion.
Okay. For both molar activation and for molar derotation and activation. A good option can be create a passive transpalatal bar. I want to draw it in blue, this nice blue.
Yes, yes. You are clever in drawing.
So here we have our transpalatal bar, and we can adapt it perfectly passive. And then we can take it out from the patient's mouth and put it on a piece of paper, and then take a pencil and draw a little bar close to the terminal of the transpalatal bar. Then we can insert and activate the transpalatal bar for derotation by activating the two terminals and checking on the paper that the angles are exactly the same. So the angle of left and angle of right are exactly the same. This is a quite easy way to check the transpalatal bar activation. This is a first idea. And then, as the colleague said, it is indicated to insert some expansion force, but it's quite easy to do. So the molar will tend to derotate and to go in a backward direction.
Yes. Okay, thank you. Another question from Dr. Ezu. He asked, in case where you intrude 11 and tipped it mesially, it was also positioned buccally. With your technique, how could you move it palatally too? Thank you
for your question. The colleague is extremely skilled because he focused the point not that easy to see. Thank you for your question, because it allows us to go in a deeper consideration in this case, to go into deep. In this particular case, the tooth was quite proclined, and we were able to reach from a lateral point of view the center of resistance, because the cantilever had a inward bending, and it's not easy to see from this perspective, but I want to help myself with a drawing. I have a picture somewhere in my computer, but I don't want to steal all of your time. I want to draw this fantastic pink tooth with the center of resistance. In this particular case, we have a gap between diastema between the incisors, and this allowed us to bend the wire so to obtain a position of the wire passing through the center of resistance. And this allowed us not to procline the tooth, to intrude it without flaring even more. Should we retract the tooth? An option could be, for example, using a second cantilever starting from the cannon, retracting the incisor. That could be an option, or we could go from the lingual side, because if we intrude it from the palatal side, we would have an intrusion with retroclination.
Thank you, Dr. Francesco. It was the last question. It was the last one. And thank you too much.
Dr. Ashraf, would you please show them the certificates of appreciation?
Yes. Now you will receive a certificate of appreciation from
It will be sent to your email. Okay, but now we have to thank you very much. Just if you give me a chance, Dr. Ashraf.
Yeah, take your time. Okay. Just wait, Dr. Francesco.
Okay, this is the one.
Your certificate.
Okay, and this is one for Dr. Nazario.
Yeah.
Okay.
Yeah.
Okay, Dr. Francesco, you will receive this for your email. Thank you very much.
Yeah.
Thank you.
Okay, Dr. Nazario.
Thank you so much. I'm very grateful.
Yeah.
Okay,
Thank you.
the finishing words is for you, Dr. Ashraf. Thank you.
Yeah. Thank you, Doctor. Thank you. Thank you, Dr. Francesco, and thank you, Dr. Nazario. Thank you too much. It's really, it was an amazing lecture, and it was very informative for me and for all participants. And I hope to meet again, inshallah, in a lot of webinars, in different meetings. And we hope, inshallah, to visit our university, to visit Egypt, and also we will visit you in Italy, inshallah. Thank you too much for all of you and for all participants. And now everyone, if you have a last call from Dr. Francesco before leaving this webinar.
Thank you. It has been a big pleasure and a big honor for me.
Yeah,
thank you. And hope to see you soon.
Inshallah. Thank you. Yeah,
Inshallah.
thank you. Inshallah. Thank you too much. Thank you. Really, I would like to thank you. And it's honor to listen